All right, ladies and gentlemen, welcome back to the Ultimate Pulmonary Wellness Lecture Series. Sorry for the late notice, but I decided to do this today because I saw a lot of questions, very interesting questions that I wanted to get out of the way before we get into some heavier stuff later this year. And the other thing is that there's a lot of new members I see joining the various Facebook groups. And so I wanted to take at least one session to sort of catch everybody up. I'm still seeing a lot of the same misconceptions out there about some basic principles, and so I think it's really worthwhile for us to go through some basics tonight. So I'm going to go through some basics. I'm going to go through a bunch of questions that I've already been sent, and then if you want to ask questions, there's two ways you can do it. You can either we can get you to call in, okay, in other words, we can make you able to speak to us, or you can type it in. And the way that you type it in is if you look at the upper right hand area of your screen, you should see a red arrow. If you open that red arrow, it's going to open up your dashboard and you'll see a space where you can type questions to me. Couple of things I want to say. As always, disclaimer, all the information that I'm about to present is my own ideas, my own thoughts based upon what I've been doing in this field since 1992 and what I've been doing at the Pulmonary Wellness and Rehabilitation Center. Don't take anything that I say as, you know, this is what Noah said I should do, or as a replacement for your doctor or anyone on your healthcare team's advice. Okay, these are not even suggestions to you. These are a sharing of my experiences, telling you what I think I would do if you were my patient based upon my experience here at the Pulmonary Wellness and Rehabilitation Center. I want to thank the American Lung Association Better Breathers Club, Serena Arabito, and also all of the people who I talk to online on the various Facebook groups. And we have a lot of good things going. I am back from vacation, feeling refreshed and ready to get going. So let's get it going. So there are certain topics, and just understand that I'm on about 35 different Facebook groups, and one of the frustrations that I have is that people ask the same questions over and over and over again, and I almost feel like we should have one giant Facebook conglomerate for the people with pulmonary fibrosis, one for the asthma people, one for the COPD people, but there's plenty of overlap there so that we should all sort of, you know, there's things that we can all learn from each other, and so keep your eyes peeled for an idea like that. But there are certain things that kind of come up again over and over again in the various groups, and that includes the obstructive diseases, the restrictive diseases, and each and every time I see it, I feel in some ways like it's like when you talk to a goldfish and then a minute later, you know, the goldfish, it seems like no matter how many times you go over it, there's still a lot of misconceptions out there about it. So I want to clear up some of those misconceptions tonight, and I think the simplest way to do it is I can take some highlights from all of the different webinars that we've done, and hopefully you'll leave here tonight with a much greater understanding of breathing, of shortness of breath, of the different diseases, and what you can do to help yourself. Okay, so let's start with breathing, okay? There are, the breathing system, or our respiratory system, is controlled by the respiratory center in the brain, okay? There's something called the central nervous system that controls everything that goes on. If we take the central nervous system is essentially our brain and our spinal cord, and that controls everything that we do, okay? That central nervous system can be divided up into what we call autonomic nervous system, and the easy way to remember that is automatic nervous system and voluntary nervous system, okay? So the big crown on top is the central nervous system. Divide that into voluntary and autonomic nervous system. So the voluntary nervous system means that I want to pick up this cup and I'm able to pick up this cup, take a drink, okay? I can raise my arms up, I can bring my arms down, but I don't have to sit here and say to my heart, beat, 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 beat. And that's a good thing, because if that were the case, then every night when we go to sleep, we would die in our sleep because our heart would stop beating, okay, if we had to control it. So the heartbeat falls under what's called the autonomic nervous system, okay? Respiration, or breathing, also falls under the autonomic nervous system as a safety net, okay, and most of the time, which is also a good thing. Otherwise, every time we went to sleep, we would stop breathing, okay? But the other thing about respiration in the respiratory system is that there are also some voluntary components to it. So in other words, if I want to breathe fast, I could go, or if I want to breathe in through my nose, out through my mouth, I can do that. Or if I want to blow out hard, I can do that as well. But there are certain things that are going on in the body that are being monitored by the central nervous system and the autonomic nervous system, so that even if you weren't thinking about your breathing, you would still take a certain amount of breaths per minute, and that would be based upon and determined by and set by the respiratory center of the brain, which is located in the medulla, okay, which is actually in the brain stem, and that responds to various different stimuli. So the main point to take away from what I just said right now is that there's a central nervous system that likes to maintain peace or homeostasis or consistency in the body. That will respond to various things, and that will create changes in the body based upon signals that it receives. So what is respiration stimulated by? Now, the obvious answer is a low oxygen level. So people think that if my oxygen level drops, that I am stimulated to breathe. In fact, there are three main things that will stimulate respiration in the respiratory center. First and foremost is not actually a low oxygen. First and foremost is an increase in carbon dioxide in the blood. Second is a decrease in oxygen in the blood. And third is going to be an increase in hydrogen ion in the blood. And what that means is essentially that our blood is becoming more acidic. Okay? So all this has to do with supply and demand. So the more active we are, the greater demand there is and the more supply we need. And in the case of lung disease, when the supply that we have is not able to meet that demand, that's when we start to have problems. So again, the respiratory center in the brainstem or the medulla responds to low increase in carbon dioxide or high carbon dioxide, decrease in oxygen, or an increase in hydrogen ion, or the air or the blood becoming more acidic, okay? Those are basics. That's a basic principle. Now, once the medulla sends a signal to breathe, okay, that signal is transmitted down the spinal cord, and it's essentially transmitted through the 3rd through 5th cervical vertebrae. So the vertebrae is your spine. So your spine is your vertebral column, and we have 7 cervical vertebrae, okay, which is our neck. We have 12 thoracic vertebrae, okay, and then we have 5 lumbar vertebrae, and then we have our sacrum and our coccyx. All those things work together to make up the spinal column. And basically, the respiratory center will send out a signal that will leave the 3rd through 5th cervical vertebrae, or the 3rd through 5th vertebrae of our neck, okay, and they will stimulate the diaphragm. Now, the diaphragm is the main muscle of inspiration. So when we talk about breathing or respiration, there's always going to be 2 phases of respiration. Inhalation or inspiratory phase or inspiration, okay, or exhalation or the expiratory phase or expiratory phase or expiration, okay? So inhalation, expiration. And we have muscles that are inspiratory muscles, we have muscles that are expiratory muscles, and we have muscles that function during inspiration and expiration. But when we talk about inspiration, the main muscle of inspiration is going to be the diaphragm. And the diaphragm essentially sits right here in our abdominal, in between our thoracic and abdominal cavities, and when it's a dome-shaped muscle, and when the diaphragm contracts, the diaphragm contracts downward like this. So in other words, the diaphragm is sitting right here. The diaphragm, so just to give you a couple of ideas, so our lungs are above it, okay? Our abdominal contents are below it. The diaphragm contracts downward. This creates a negative pressure, and that negative pressure is what inflates the lungs, okay? Now, the muscles of expiration, or the main muscles of expiration, okay, there really are no main muscles of passive or quiet expiration, because what's supposed to happen is this is an active process when the diaphragm contracts downward, okay? That creates a negative pressure filling the lungs, but the way that the lungs are supposed to exhale is the natural recoil of the lungs. And so when you have a lung disease, there's a disruption somewhere along the way, either during that inspiratory phase or that expiratory phase. And I hope that makes sense to people so far. Now, what I said is that the inspiratory process, or inspiration, is an active process that is triggered, okay, when there's either an increase in carbon dioxide or a drop in oxygen or an increase in hydrogen ion or increased acidity in the blood. A signal is sent down. It comes out the 3rd through 5th cervical vertebrae. It triggers the diaphragm to contract. The diaphragm contracts downward. That creates a negative pressure, and it's that negative pressure that inflates the lungs. Okay? Now, the lungs should naturally, because of their recoil, go back to their resting position. But when we are exerting ourselves, we have what's called a forced exhalation or forced expiration, okay? And that forced expiration is actually done by the muscles of the abdominals, okay? So the abdominal muscles are the main muscles of forced exhalation, okay? Now there are also a whole bunch of other muscles that are what we call accessory muscles of breathing, or respiratory accessory muscles. And these include the muscles of the neck. So there's a muscle there called the sternocleidomastoid, the scalenes, the pectoral muscles of the chest, the latissimus dorsi of the back, the shoulder muscles, the abdominal muscles, the intercostals, both internal and external. So all of these muscles can function to help you with breathing as accessory muscles of breathing when the diaphragm is not working effectively. Okay? So I hope that all makes sense, but I'm going to say it just one more time. Okay? So the main muscle of inspiration is the diaphragm. The diaphragm is triggered by the medulla when we have either a rise in carbon dioxide, a drop in oxygen, or a rise in hydrogen ion. A signal is sent down the spinal cord. It comes out the 3rd through 5th cervical vertebrae. It stimulates the diaphragm. The diaphragm contracts downward, creating a negative pressure. That negative pressure causes the lungs to inflate. In an ideal healthy situation, which we know many of us are not in, the lungs will naturally go back to recoil on their own. Okay? That is respiration in a nutshell. Okay? And please understand, why am I doing the same thing over and over again? Because I can't teach you about things that are at level 5 or level 10 until I teach you and you understand clearly the things that are at level 1. Okay? So that's the basics of normal respiratory physiology. Normal respiratory physiology. Now, let's talk about abnormal respiratory physiology. And when we talk about lung disease, okay, again, remember I told you before, the autonomic nervous system or the central nervous system is divided into autonomic and voluntary, and then autonomic can be further divided into sympathetic and parasympathetic. When we talk about lung disease, there are 2 major classifications of lung disease, major classifications. So understand what these 2 classifications are. These classifications are what we call obstructive lung disease and restrictive lung disease. So some diseases are going to be obstructive lung diseases and other diseases are going to be called restrictive lung diseases. When we talk about obstructive lung diseases, okay, what we're talking about are people who have difficulty blowing air out. And these are going to be people with COPD, chronic bronchitis, emphysema, asthma, cystic fibrosis, sarcoidosis in some cases. So if you have an obstructive disease, that means you have problems with the expiratory phase of respiration. If you have a restrictive disease, what that means, okay, and these are things like pulmonary fibrosis, IPF, we talked about all the different interstitial lung diseases last month with Dr. Kainer, but when you have a restrictive disease, okay, what that means is you have difficulty taking air in. Again, if you have an obstructive disease, you have difficulty blowing air out. If you have a restrictive disease, you have difficulty taking air in. So what does that mean, though? What it means is that in a similar way to a yin and a yang, or an up and a down of an elevator, okay, if you have difficulty with the up phase of an elevator, then you ultimately have difficulty with the down phase. And same thing with respiration. So if you have difficulty with inspiration, then eventually you're going to have trouble with expiration and vice versa. And so the hallmark of both obstructive disease and restrictive disease, although there are quite a few differences, the overwhelming hallmark of obstructive and restrictive disease is shortness of breath. And that is why most people go to see the doctor for the first time, or a cough. Okay? So since we talk about shortness of breath over and over again, I'm going to talk about it one more time, and probably 1,000 more times if you keep tuning in. But it's important to talk about shortness of breath, okay? When we talk about breathing, okay, it's very, very important to understand that breathing is a multifactorial process. And what I mean by that is that there are many different factors that can contribute to how well or how poorly you breathe. It is not just the respiratory system or the lungs, okay? So what that means is you can actually become significantly more short of breath with absolutely no worsening of your lung function. You can become significantly less short of breath with absolutely no improvement in your lung function, okay? Now, people are scratching their heads probably, and if you're not actually doing it right now, I see people figuratively scratching their heads in the different groups when they talk about these things, and people say, well, I don't understand this. I'm much more short of breath. How can my lung function be the same? Or I feel much better. Why didn't my lung function get better? And there's, again, many, many reasons for this. So some of the things that can make you more short of breath are inactivity. So if you've become less conditioned or deconditioned, okay, that can make you more short of breath, even if your lung function has not gotten worse. If you've put on 20 pounds, that can make you more short of breath, okay? If there's something wrong with your heart, okay? So all of this boils down to what we talk about as being aerobic capacity. And aerobic capacity is essentially a measure of how much work can you do, how good is your body at using oxygen. And how your body uses oxygen is based on three major factors. And those three major factors are how good are your lungs at moving air in and out, how good is your heart at pumping blood, and then how good are your muscles at extracting and utilizing oxygen from the bloodstream, okay? So again, how good are your lungs at moving air in and out? How good is your heart at pumping blood? How efficient are your muscles, okay, at extracting oxygen from the bloodstream and using them efficiently? So if any of those gets better, okay, and the others stay the same, then you can expect an improvement in your overall aerobic capacity. If any of those get worse and the other stays the same, then you can expect an overall decline. But what we know is that generally one can go up, one can go down, and it's very difficult sometimes to isolate exactly what is coming from where. But in general, a basic rule is that the more you do, okay, and the more that you exercise, all three can get better. Despite what many people believe, I'm a firm believer that you can improve lung function, and I'm not a believer in it in the same way that I believe in the Easter Bunny or Santa Claus. I'm a believer in it because I have documented evidence of it in the past, 17 years that I've been the program director at the Pulmonary Wellness Center, where we've done over 67,000 exercise sessions with people just like you. And we know for a fact that you can improve lung function if you do the right things, okay? The overwhelming majority of literature, when you talk about pulmonary rehab, they will say patients may feel less short of breath, they can do more, but there's been no improvement in lung function. And my strong belief in that, and the reason for that, is that people are not generally exercised enough. I think a lot of times when people are short of breath or they're experiencing chest discomfort, the advice is overwhelmingly going to be, well, why don't you take it easy? The problem with that, even though that may make you more comfortable now, is that down the road, that's going to make you even more uncomfortable, okay? So if we think about the fact that typically when people start to get short of breath or start to become aware that they have an actual lung problem, okay, this will typically occur at high levels of activity. Things like walking upstairs, walking uphill, carrying heavy loads, walking fast. Okay, the higher levels of activity that may be in the outliers of what we do every day. So in other words, you may not have to walk uphill every day, and so all of the muscles that you use to do those activities, get weaker, and then when you do have to walk uphill, that's when you become more aware of your respiratory problem. So as I mentioned, typically when people start to get short of breath, it happens at high levels of activity, and the overwhelming nature of human beings is to avoid the activities or curtail or change the way that they do these activities that cause them discomfort. And the problem with that is that once you stop walking uphill or once you stop walking upstairs, all of the muscles that you use to do those activities, including the heart muscle, get weaker. Those muscles become less efficient at using oxygen, and as a result, now you start to get short of breath at lower levels of activity. So maybe now you get short of breath when you're walking on flat surfaces, and as a result, you now walk less, okay? And so now all the muscles that used to help you walk a mile now get weaker. They are less efficient, they don't use oxygen as well, and now you get short of breath walking lesser distances, and you eliminate those, and so on and so forth. Now, hear what I'm about to say, because this is a very important fact that many people won't tell you, including doctors, okay? All of that can occur with no change in your lung function. And what I mean by that is that you can get weaker, you can do less, you can be more short of breath, and if we do your PFT, it may be exactly the same as it was a year ago, and you look and you say, I don't understand this, I'm more short of breath. How is this possible, okay? And as I mentioned, there are many, many factors that go into how well or how poorly we breathe. And so we call this the dyspnea cycle. Dyspnea refers to the patient's perception of shortness of breath, or the shortness of breath cycle, where you start to get short of breath at high levels of activity, eliminate those, decondition, get short of breath at lower levels of activity, eliminate those, get short of breath at lower levels of activity, and so on and so forth. Another point that is very important to realize is that in the same way that you can spiral downhill, if you start to make some lifestyle changes, and in other words, just reverse the negative lifestyle changes that you've made, you can actually start to spiral uphill again. And so I'm going to go now to one question that reminds me of this, what we're talking about now. So here's a question that I got during the week. It says, wow. Actually, I saw this on. Has anyone had their pulmonologist tell you that there is nothing else that they could do for you and see them in 6 months? Okay? And this is something that we hear all the time. And I'm happy to say we don't hear it from every doctor, but you know, there are going to be certain people who are going to say to you, you know what, I've done everything I can for you. There's nothing else I can do. Now, when a patient hears that, very often what they think is, oh man, there's nothing else I could do for myself, okay? So that can be very discouraging for patients, but very often, it's important to understand that very often what the doctor means is that you are maximized from a medical perspective, meaning that you're taking all the medications that you should be taking at their maximum dose, and there's nothing else that I can do or that they can do from a medicinal point of view. But that is where lifestyle change comes in, and that is where the whole concept of ultimate pulmonary wellness comes in. And as you know, I believe that there are really 5 factors involved in ultimate pulmonary wellness. And those are medical, meaning having the right doctor, taking the right medications, and taking those medications properly, 20%. 20% is exercise, meaning exercising regularly, doing the right exercises. Nutrition, so being at the proper weight, not being underweight, not being overweight. Stress management, relaxation training, and then prevention of infection. So even though your doctor says there's nothing else I can do for you, if you're not making efforts in all 5 of those areas, okay, meaning to be more compliant with your medications, to make sure that you're using the devices properly and taking them properly so that you get the maximum benefit, exercising regularly, eating healthy, losing the weight you need to lose or gaining the weight you need to gain, and taking measures to prevent infection, things like, you know, washing your hands frequently, getting the flu shot, getting the pneumonia vaccine if your doctor says so. If you're not doing those things, then you are not doing all the things that you can do for yourself. So don't be, you know, don't rely on other people to do it all for you. At this point, we all have to say, well, what can I do to make a lifestyle change? So again, let's go back to shortness of breath. So as I mentioned, people typically get short of breath at high levels of activity. They avoid those, and so on and so forth, okay? So let's talk about the different ways that we can attack shortness of breath, okay? Let's talk about obstructive disease versus restrictive disease one more time, okay? So for obstructive disease, again, you are going to have difficulty blowing air out. And so typically the patient who has obstructive lung disease will often wind up with bigger lungs that they cannot exhale the air. They cannot clean the air out. And so there's not good gas exchange, there's not a good removal of stale air, and a good bringing in of good, healthy, oxygenated air. So they will typically wind up with a bigger lung, okay? We'll often see people who have what we call a barrel chest, meaning that they're so inflated, they're what we call hyperinflated, and therefore they cannot blow the air out. Now, another issue that comes down here is that when the person is hyperinflated, those lungs push down on the diaphragm. Remember, the diaphragm is the main muscle of inspiration. It's supposed to be dome-shaped, but when your lungs are hyperinflated, it gets pushed down and it functions at a poor mechanical advantage, making you even more short of breath, okay? When you have a restrictive disease, okay, such as an interstitial pulmonary fibrosis, you have difficulty taking air in, and therefore people with restrictive diseases will typically have smaller lungs and smaller chest walls. Okay, again, any way you slice it, okay, any way you slice it, both are going to lead to shortness of breath. So now, let me get to some of the questions, okay, and I'm going to take some of the questions that I got during the week. I'm going to clear up some of the debates, hopefully, and then I'm going to go to audience questions from tonight. So here's a topic that I hear debated over and over and over again. People will say, I was told I have emphysema, but I don't have COPD, or I have COPD and emphysema, or asthma is COPD, but chronic bronchitis or asthma or emphysema is COPD, but I have emphysema, but I don't have asthma. And I've seen these variations over and over and over again, and I'm sure if I go back in the archives, I will find every single possible variation. Let me clear it up, okay? And please understand that this is not something that I think. So what I'm about to tell you right now, you can put in the bank, okay? COPD, when we talk about COPD, chronic obstructive pulmonary disease, we are talking about two diseases, and those two diseases are chronic bronchitis and emphysema, okay? I see written a lot of times, well, this is an umbrella term that encompasses a lot of different diseases, or, you know, there's many different diseases that fall in it. That is not true, okay? And that is not the way the classification system works. So a lot of times people will say that something's complex, or that there's many factors involved, and that may be true. But if you truly understand the disease, then you should understand the complexities. Like, in other words, I understand that there are many factors involved, but I understand the diseases well enough that I can explain the complexities to you, and I also know the specifics. So just saying that, you know, there's many diseases, or it's a group of diseases, or this and that, is not enough, okay? And that's why there's a lot of confusion. So let me just say it again. COPD is two diseases. It's chronic bronchitis and emphysema. When we talk about chronic bronchitis, okay, what we're talking about is diseases of the bronchi or the large airways, okay? So chronic means it's ongoing, it's not acute. Acute is the opposite of that, okay? It means that it's a disease that you have, it stays with you. Obstructive means, again, you have difficulty with the exhalation phase, okay? Pulmonary means related to the lungs and the respiratory system, and we know what disease means, okay? So again, COPD is not a group or an umbrella term that encompasses many, many different diseases. That's confusing to people. Hear what I'm about to say again. COPD is chronic bronchitis, which is disease of the large airways or the bronchi, and emphysema is disease of the small airways and the alveoli, which are the air sacs where gas exchange actually occurs, okay? Recently I read something about people saying, oh, well, asthma is COPD. Hear what I'm about to say. Asthma is not COPD. COPD is two diseases. Say it with me. They are chronic bronchitis, emphysema. If it's outside of chronic bronchitis and emphysema, it is not COPD. Now, here's where it gets confusing. Asthma is a COPD, meaning that it is a chronic disease. It is an obstructive disease, and it is a pulmonary disease. So you say to yourself, well, why isn't it COPD? That's just the way it is, okay? And I recently saw an article on a professional file, and I then started seeing patients referring to this on Facebook, saying that they're going to start including asthma as one of the COPDs. And so the COPDs would then be emphysema, asthma, and chronic bronchitis. No, they're not. And if they do, they shouldn't. Why? Because it's stupid to do it that way, okay? And listen to why, okay? These things make sense if you think about it. It makes sense to include COPD as emphysema and chronic bronchitis. And the reason why it makes sense to include emphysema and chronic bronchitis together is because more often than not, the causes are the same, and the number one cause, as you know, is probably cigarette smoking. Or I should say, as you probably know, is cigarette smoking. Not as you know, is probably cigarette smoking. We know it's cigarette smoking. So the causes are the same. The characteristics of the disease are essentially the same, meaning that the hallmark is shortness of breath, okay? The other hallmark of it is that it's non-reversible, okay? And I'll explain what that means in a few minutes. Don't take that to mean that it can't get better. And the treatments are essentially the same. So think about it, okay? The cause is the same, the characteristics are the same, the treatments are the same. Therefore, it makes perfect sense to include chronic bronchitis and emphysema in the same category. Now, here's why asthma should never, and I will get my placard ready to fight against asthma being inducted into COPD, because asthma has different causes, okay? The characteristics of asthma are significantly different than the characteristics of emphysema and chronic bronchitis. So we see clear-cut differences between these two and this one, okay? And the treatment is different. So anyone who's fighting to say, hey, yeah, we should have asthma and COPD, that's like saying having a cat in the dog club. It doesn't make sense, okay? So please understand, if you understand it any way, or you make a case on Facebook that asthma is a COPD, I'm going to call you out on it, because it's just wrong, okay? And if a doctor tells you that, you know, asthma is a COPD, I would say to myself, check please, because that's just not the case, okay? So one more time, COPD, two diseases, not an umbrella of many diseases. Chronic bronchitis, disease of the large airways, which are the bronchi. Emphysema, disease of the small airways, and the alveoli, which are the air sacs where gas exchange occurs. On the other side, asthma, not COPD, okay? How do we know the difference between COPD and asthma, okay? And here's something else that's a good thing for you to understand. Also titled, what do I learn from this PFT, or pulmonary function test? Think about when you get a pulmonary function test, okay? How is it done? One of the first things that you're asked to do is you're asked to take a deep breath in, right? And you're asked to take as deep a breath possible, and then you're asked to blow out as hard and fast as you possibly can. Now, the reason for this maneuver is that this hard and fast, or what we call forced exhalation, okay, or forced expiration, will actually trigger the obstruction of an obstructive pulmonary disease, okay? So in other words, that brings out the pulmonary obstruction. So in the same way that a cardiac stress test will bring out the chest pain of heart disease, this maneuver, meaning a forced expiration, so think about when you hear FEV1, right? That's forced expiratory volume, okay? Okay, that is going to trigger the obstructive nature of the disease. Now, in both of these cases, and here's where they're similar, in both of these cases, we can actually see an obstruction in patients with COPD and in patients with asthma, okay? Now, where it gets different again, and again, why my case gets stronger that asthma is not a COPD, or is not COPD, it is a COPD, and is the following, okay? What happens next is you're given a bronchodilator, right? In the patients who have asthma, we're gonna see a significant improvement or a significant reduction in their obstruction once they take that bronchodilator, okay? And here again, so the patients who have asthma as compared to COPD are going to see a significant improvement once they take that bronchodilator. And that's the dividing line. So for the patients that show this significant improvement, they have what we call reversible airflow obstruction, and they then get classified as a patient with asthma, okay? If there's not a significant improvement, and I'm for some reason drawing a blank now on what the percentage is, I think it's like a 10% improvement that makes it significant, but for the patients that have COPD, that is called an irreversible or fixed airway obstruction, and those patients will not respond well to the bronchodilator. In other words, we won't see an improvement in response to bronchodilator, okay? So is asthma a COPD? I think I've made the case that it is not. Is it COPD? It is a COPD. Again, I hate to keep it. You see why it's confusing. Okay, but again, COPD, emphysema, chronic bronchitis, asthma is asthma. Other points now. Now, some people are going to say, well, if the bronchodilator doesn't do anything for COPD, and I have COPD, why am I taking a bronchodilator? Right? That's a good question. So the thing is that we know that there are some patients who, even though we don't see a significant improvement objectively on the PFT, there is still a significant subjective improvement in how the patient feels. So they feel like they're breathing a little bit easier, and if there's this subjective improvement, then it's certainly worthwhile taking. Okay? So I really hope that that clears up the difference between COPD and asthma. And again, this is not really up for debate. And, for those of you that know me, I think you know that I'm pretty careful in what I say, in the sense that I really only say things that I know for sure. And if I'm not sure about something, I'll say I'm not sure. And if I don't know anything about it, I'll say I don't know anything about it. But what is COPD and what is asthma, I know pretty well. Okay, so let's go to a couple of other questions. Now, there was a question this week about the relationship between inhaled steroids and either cataracts or glaucoma, okay? And the reason why this question kind of confused me was because there was talk about washing your hands after you take it and not putting it in your eyes. And, I did some research on it. I didn't want to ask about it, but I did some research. And let me just clarify the relationship between inhaled steroids and cataracts and glaucoma. So first of all, let's talk about what is a steroid. So a steroid is an anti-inflammatory agent, okay? And for most medications, you can take them in a number of different ways. So you could take them orally, meaning in a pill form or a suspension form. You can inhale them. You could get them through an IV. You could get them intramuscularly, okay? But when it comes to steroids, the talk almost always goes to the fact that steroids come with a lot of side effects to them, okay? So the number one, let's talk about what we're talking about, first of all. So the big steroid that we're talking about, the giant elephant in the room, is prednisone, okay? We know that prednisone, when you need it, you need it. We know it makes you feel a whole lot better, but we know that it's got a tremendous amount of side effects that are systemic in nature, including weight gain, including an increase in blood sugar, including osteoporosis. And the reason why inhaled steroids are of such great benefit is because, as opposed to taking a pill that has to be digested by your stomach and then has to be spread throughout your blood, okay, that goes to every system in a very, it's not discriminate. It doesn't say, okay, we're not going through the pancreas, or we're not going to the bones, or we're not going to this. Okay, it goes to all systems of your body. So whether you want it or not, your joints start to feel better because they have the anti-inflammatory benefit of getting this prednisone. So the beauty of inhaled steroids is this, okay? Number one, they don't act systemically. You don't have to take a pill, so they don't have to go through your bloodstream, okay? They go directly to the area that you want to treat, meaning that you breathe them in, they go through your respiratory system and into your lungs. So we minimize the systemic effects. They're direct to the site that we want them to use, and as a result, they work fast, and people can get some improvement without having, the fear of osteoporosis or cataracts or glaucoma or diabetes and so on and so forth. So the question came up this week, and I really didn't have a great answer for it, so I did some research. And let's just talk about, there are some big studies that have been done, And let me just tell you some of the results. I'm going to read for a second, and then I'm going to simplify it for you. So essentially, the answer was, okay, the question was, were people who were treated for elevated eye pressure? So when we talk about glaucoma, we're talking about elevated eye pressure. When we're talking about cataracts, okay, the question was, were people with elevated eye pressures or cataracts more likely to be taking inhaled steroids than a comparable group without elevated eye pressure? So in other words, they studied people, they saw who had increase in eye pressure, and then they said, of these people with an increase in eye pressure, are they more likely to be taking an inhaled steroid than the people who don't have an increase in eye pressure? And the answer was no. Okay? However, when they further analyzed the data, what they found was that the larger percentage of the elevated eye pressure patients were taking high-dose inhaled steroids. And high-dose, they meant more than 1,600 micrograms a day for at least 3 months. So if we talk about what we're talking about, and it's a little bit of an older study, so some of these medications will be not on the market anymore, but Beclovent or Vanseril, at least 32 puffs per day. Asmacort, 16 puffs per day. Aerobid, 6 puffs per day. Pulmicort, 8 puffs per day. Flovent, at least 7 puffs per day. So if you think about that, okay, most of us, if we are taking an inhaled steroid, and you have to understand that even if you don't take those medications that I just said, a lot of the combination drugs now, the things like Symbicort and Advair and Dulera, they have a steroid in them in addition to the bronchodilator. But the overwhelming majority of people with asthma and COPD are taking a much lower dose than those that I just mentioned. So if you are taking them at the high dose that I just mentioned, the risk of having elevated eye pressure or glaucoma was 40% above normal, okay? However, okay, at low and medium doses, okay, which is what the overwhelming majority of people with COPD and asthma are taking, inhaled corticosteroids pose no significant risk to vision and the eyes. At high doses, now at high doses like that I just talked about, some of the medication will enter into the bloodstream, okay, and potentially cause an increase in the risk of glaucoma and or cataracts. But here is the big caveat, okay? Before you go right out and say, you know what, I'm not taking my Flovent anymore, okay? Just think about it. The beauty of inhaled steroids is that you don't get those systemic effects that you get by taking prednisone. And why do you take inhaled steroids? So that you don't have to take prednisone. So any way you slice it, a minute dose of oral prednisone or IV Solumedrol that's an inhaled systemic or IV systemic steroid that's going to go through your body and have systemic effects is going to have a significantly higher effect than even the high doses of those inhaled corticosteroids. So Bill, I hope you're listening. I did a good amount of research on this, okay? I spent about 30 minutes on this, which, you know, is a good amount of time. I looked at about a dozen studies. In summary, the connection between inhaled steroids and cataracts and or glaucoma, minimal unless you're on very, very high doses. But again, even on those high doses, you are still at lesser risk than if you were taking oral or IV steroids. Okay, what do we do about that? A routine eye exam to test for cataracts or glaucoma is appropriate for anyone over age 65, especially if using inhaled corticosteroids on a regular basis. Bottom line for anything, when in doubt, check it out. Always err on the side of caution. All right, next question. Would it be possible to address the cause of episodes of increased anxiety that occur in COPD? I realize that being short of breath can be a cause, but there are occasions where anxiety attacks seem to come out of nowhere. Is there a physiologic reason for it? Do I have any suggestions about what would be the best way to work through these attacks? This is a great question, and it's an important question, and it again illustrates sort of what I spoke to you about before, which is the fact that there are many cycles here. Okay, so remember I spoke about the dyspnea or shortness of breath cycle, where you get short of breath, eliminate those activities, get weaker, get more short of breath, so on and so forth, and it's cyclical. This is another one of those cycles, okay? And understand this. I had a conversation with Chris, who is my tech guy, who's about an inch away from me. Not an inch, thankfully, 3 feet away from me. And we were talking about the idea of becoming an EMT, okay? And the idea behind becoming an EMT is that when an emergency occurs, there are certain things that naturally pop into your head that you have some tools to use, as opposed to somebody who's totally untrained. When emergency occurs, okay, and something goes wrong, that's where this sort of panic and emotion takes over, okay? The whole idea behind what I try to teach you every single week is to give you these tools so that when something goes down, you can say stop and visualize my face, and I'm sorry it's this face and not Brad Pitt's face, but visualize my face and say, stop, I know what to do here. I have tools that I can use in this exact situation. So when you're walking up the stairs, okay, and you start to get short of breath, you can say, stop, I know what to do here. In through your nose, out through your mouth. In for a count of 2, out for a count of 4. Now please understand, this is a review session. It's my way of reviewing for many people, and it's my way to introduce others to these concepts. Almost all of these topics, and as a matter of fact, everything we've spoken about tonight, with the exception of the cataracts and the glaucoma, is in at least one webinar on our website that has already been posted, okay? And that website is www.pulmonarywellness.com under web archives, okay? So everything I've talked about, the whole bachelor's program, master's program is all up there for you to read and access anytime you want. It's free, it's my gift to you, it's my hope that you're gonna use it and learn from it and be able to apply it to your life. And the reason why what we used to do was every year before we were doing webinars and archiving the webinars was we would have the same 12 webinars every year, and every January we would do this, and every February we would do this, except now I don't think you want to hear me say the same thing over and over again any more than I already do. So I've put them all online for you to use at your convenience. But this year, as you know, so much of what we're doing is meet the doctors, and I'm bringing in these super geniuses of medicine to talk about the exact things that people with pulmonary disease need to know. And so help yourself get the most out of these activities and these different lectures by learning the basics. And that's what I'm doing tonight, is bringing in all the basics. So again, what was I just talking about? That's a good question. Okay, so we were talking about anxiety, okay? It's a good thing I saw the paper, otherwise I would have had completely forgotten what I was talking about. But anyway, so anxiety, let's think about this, okay? Let's go back to the central nervous system. So the central autonomic nervous system, and I do realize it's 7:18. Don't worry, there's still a lot to cover. We're probably gonna go to 8 o'clock because I know there's a lot of questions here, and I'm gonna get to about as many of them as I can, okay? Because this stuff is important. So don't worry about time. We're not finishing in 11 minutes, unless you want to, in which case turn your computer off. Here we go, anxiety, okay? We talked about the central nervous system, and we talked about the autonomic versus the voluntary nervous system. So autonomic is automatic. I don't have to think to tell my heart to breathe or my blood vessels to constrict and dilate, or myself, rather my heart to beat or my respiratory system to breathe. These are done automatically by monitoring different things. The autonomic nervous system can be further divided into what we call the parasympathetic and the sympathetic nervous system. The sympathetic nervous system is based on the production of adrenaline in our body, okay? And that is known as fight or flight or freeze, okay? So if somebody jumps you on the street, your body puts out a tremendous amount of adrenaline so that your heart pumps faster, so that blood is diverted away from your GI system and away from your stomach, so that it goes to your muscles so that you can either fight or you can run away. That's the sympathetic nervous system, okay? The parasympathetic nervous system is the exact opposite. So think about Thanksgiving dinner when you've just had a giant meal and all that blood is going to your gut and you feel very sleepy, and if I said to you, come on, let's go out in the street and play football right now, that's the last thing you would want to do, okay? And I'm thinking of my Thanksgiving, maybe that's very different than your Thanksgiving, but you get the idea, okay? Now, when we get the whole idea of these two systems, both the parasympathetic and the sympathetic, came about millions of years ago, okay? So that if a caveman was walking outside of his cave picking berries, and all of a sudden a saber-toothed tiger jumped on him or a pterodactyl tried to pull him off, into the sky, he could fight him off or run. Okay, you don't have to start to think about, okay, I better divert this blood away from my stomach and to my legs so that I can haul out of here. Okay, the problem is that in today's society, and I'll say modern industrialized society, okay, very few of us have to fight off pterodactyls or saber-toothed tigers. Although last week I did have to fight off a hammerhead shark, but the overwhelming majority of us are putting out this adrenaline for situations, and in situations that are much less serious than that. So let's say someone cuts us off on the road. We feel ourselves getting mad, okay? Our body's pumping adrenaline out into our system. Our heart is pumping hard and fast. Our blood vessels are constricting, raising our blood pressure, and we're starting to get more and more short of breath, right? Does that sound familiar? Okay, well, here's the thing, okay? When that adrenaline comes out, and now you start to feel yourself get more short of breath, guess what? Being short of breath is very anxiety producing. And so I'm starting to feel short of breath, and now I'm starting to feel anxious. And guess what? My sympathetic nervous system is kicking in. It's throwing adrenaline into my system. And guess what that adrenaline is making me do? It's making me breathe harder and faster. And we know that if you have any type of obstructive or restrictive disease, the harder and faster you try to work to breathe, the actual, I'm sorry if you hear that clanking noise. I'm in an old New York City building, and that's my heat coming up. So I apologize for that. Luckily I talk loud. So again, if you're getting anxious and that sympathetic nervous system's kicking in, putting that adrenaline out into your system, and you're now working hard and fast to breathe, okay, that actually causes the airways to constrict. It causes an increase in air trapping, and you actually have to work harder and faster to breathe. So now you're even more short of breath. Guess what? Now we're more anxious. Now we're triggering more adrenaline being pumped into our blood. And again, this is another cycle that if you start to understand these concepts and implement them, and don't wait till you're, up the creek without a paddle to try them out. Start trying these things out when you're calm, when you're feeling good, so that when something goes wrong, you can say, stop, I know what to go here. I know what to do here. And so what you have to do in those situations, again, stop, I know what to do here, calm down. Everybody just take a nice deep breath now, in through your nose, out gently through your mouth, and you notice after the first or second breath, all of a sudden you start to feel a little bit different. Your shoulders feel a little more relaxed. You can move air a little more easily, okay? But again, it's understanding these concepts when you're not under pressure so that when something goes wrong, you can actually do it, okay? So for this, I'm gonna refer you, because I know we are a little short on time, I'm going to refer you to a couple of webinars that are on the website, okay? And for these ones in particular, I'm going to refer you to, there's a couple, and in particular, there's one that's called Your Best Breathing. I'm going to refer to these. They're on www.pulmonarywellness.com, and there's one called Webinar Number 3, Breathe Deep, Your Absolute Best Breathing Techniques Ever. And in those absolute best breathing techniques, I'm going to teach you about pursed lip breathing, diaphragmatic breathing, paced breathing, and also positions for recovery from shortness of breath, so we don't have to do them right now. Okay, let's move on to other questions. So here is a question, and this question is about exercise in particular, okay, Zumba Gold. Okay, so people talk about what are the best exercises, and this is kind of a funny journal post, and I'm gonna talk about some highlights from it. So it says, okay, your doctor says to you, you need to exercise. It's the best thing you could do for yourself. And what's the first visual that comes to mind? The big room full of equipment where people were vigorously exercising, and you say, are you freaking kidding? Okay, so there's one thing, okay? So most people, when you're feeling short of breath, or you're feeling weak, or you're feeling lethargic, the last thing you want to be doing is exercising, okay? But it's really important, as I mentioned before, based on the dyspnea cycle, that no matter where you are right now, this is your starting point. And I've had people, people ask me about the different classes of lung. What functional status are you? Class 1, Class 2, Class Stage 1, 2, 3, 4. I've had people with very severe lung disease, with lung function in the teens, okay, that have been able to make significant improvements. So anyone that tells you there's no way that you can get better, unless you're doing all 5 of the components of Ultimate Pulmonary Wellness every day to their maximum, you're not doing everything that you can for yourself. So you can always get better, okay? So the question is Zumba, okay? So as we've dealt with this disease, those that do best learn that while we may do things less frequently and slower, there is much that we can still do. So why not Zumba or dancing? We're a generation that grew up loving our music. Put on your favorite music, set a tempo you can handle, and move. So my neighbor invited me to the senior center for the Zumba Gold session. Yesterday I knew I couldn't be there at the start and chose to observe instead. Gee, it was like pulmonary rehab with music. And that statement alone says to me, if you're going to pulmonary rehab and they don't have music, something's wrong. You need to have music at pulmonary rehab. We run a place like Studio 54. So here's the thing. It was interesting just how much of what is incorporated into the exercise portion of pulmonary rehab can easily be built into the dancing, including using light weight to increase effort. Zumba, if you don't know, is essentially done to Latin or Spanish music, and it's dancing, and it's a full body workout, so it's aerobic, and it exercises all the muscle groups of the body, okay? Now, there is a webinar, okay, and there's multiple webinars on exercise. The first one is webinar 7, Move It, Exercise in Pulmonary Disease. Let me just say this, okay? The overwhelming majority of people who come to a pulmonologist for the first time, and I'm not saying everybody, but the overwhelming majority have become sedentary, or at least less active than they were before due to their disease, okay? And so the point is that it almost doesn't matter what you do. Like Nike says, just do it. I say just do anything. Now, of course, there are going to be some exercises that are better than others, but if you can do Zumba, by all means, it's a great aerobic exercise. It's a great, especially if they're using weights, it's going to be a great strengthening exercise, and it's going to be a great overall workout for your body. Now, the key to keep in mind is that if you go to a class where they're doing vigorous exercise, do it to your tolerance. Don't go there and, like Rodney Dangerfield, think that you have to do every single thing that the instructor does until you're, lying on the floor gasping for air. Go at your own pace. But again, let me just say one thing. When we talk about exercise, there's different types, okay? In general, we talk about aerobic exercise or strength training or flexibility training. The overwhelming majorities of exercises that you do will have some benefit in all areas. So if we use the treadmill as an example, in almost all cases, the treadmill is considered an aerobic exercise, but if you haven't been doing anything, you're going to get some strength benefits of that, and you're also going to get some flexibility benefit from it. So, Barbara, my answer to, what do I think of Zumba? If you could do Zumba, by all means, and you enjoy Zumba, do what you enjoy, because if you really choose an exercise that you hate, the likelihood of you doing it is going to be less than positive. So I encourage you to choose whatever exercise you're going to do on the regular basis, because we know that consistency over time is much more important than any 1 week or day or month of exercise, okay? Here's something else. Somebody looked at a journal entry and they said, my doctors and nurses say aerobic stuff is not going to help our condition. Weightlifting is the best thing that you can do. Again, I say to that doctor who says that people with cardiopulmonary disease shouldn't be doing aerobic exercise, I would say, where did you get your degree? Or I would say that these people, I would say if you think that if you treat cardiovascular and pulmonary patients and you think that aerobic exercise is not going to do anything for them, then that tells me that there's a really poor understanding of the physiology. Aerobic exercise is #1 priority for anybody with a cardiovascular or pulmonary disease, followed by strength training, followed by flexibility exercise, and followed by balance training. Don't go tell your doctors that I said ask them where they got their degree. Please don't, okay? That's not my point. My point is that aerobic exercise is extremely important and done right, okay? The overwhelming majority of literature on pulmonary rehab programs over the last 25 years focuses on low intensity, long duration exercise. And my point and why that's not effective and why most programs don't see improvement in lung function is because if you are at level 3 and I exercise you at level 1, then you could do that till the cows come home, but you never get better. if your life requires level 5 and I exercise you at level 3, you could do that till the cows come home, your life never gets better. But if your life requires level 5, and by hook or by crook, and that means if I have to bribe you with oxygen or money or candy or whatever it is, and I'm being facetious, as I'm sure you realize, except about the oxygen part, whatever it takes for me to get you that biggest workout, if I can exercise you at level 8, then guess what? Your life actually gets better. And believe it or not, your pulmonary function gets better regardless of what other people say. So I have the proof. Okay, I know this for a fact. This is not something I'm guessing, and you know, I'm not like as seen on TV, I'm not making false claims, because the bottom line is I have to face my patients. So done right, aerobic exercise, vigorous aerobic exercise can improve lung function and should be done. All right, another question. If you have pulmonary fibrosis with pulmonary hypertension, 2, does that alter the duration or resistance when exercise? Does the addition of pulmonary hypertension change the whole way in which to get exercise in? So later this month, on I believe the 25th, or next month on the 25th of February, and I'm just going to check my calendar quickly, we are going to have one of the foremost experts on pulmonary hypertension, Dr. Evelyn Horn, on my show for Meet the Doctors. But let me just say it in a nutshell. The issue with pulmonary hypertension is that when you have pulmonary hypertension, that means the pressures in the pulmonary circulation and the right side of the heart are increased. Now normally, if we think of the heart as 2 hearts, we have a left heart and a right heart. Okay, the left side of the heart we think of as the left heart, the right side as the right heart. Normally the left side of the heart, or the left heart, is the high pressure side because it's that ventricle that has to pump blood throughout the whole body. The right side of the heart is normally considered, or normally acts as, the low pressure side of the heart because it just has to pump blood from here to the lungs and the pulmonary circulation. When you have pulmonary hypertension, the problem is that the pressures are elevated in both sides of the heart, and the right side of the heart is not meant to take those kind of pressures, and as a result, this can lead to heart failure. So while having pulmonary hypertension doesn't change everything about the exercise, okay, the principles are the same and the safety principles are the same, okay? But we do have to be a little bit more careful about monitoring your pressures, about, you know, making sure that you're not holding your breath, although nobody should be holding their breath during exercise. There are some other considerations for pulmonary hypertension, which I will address with Dr. Horn in February. But the thing is that we've had tremendous success with patients with pulmonary hypertension. And it's similar now with pulmonary hypertension to what COPD and pulmonary fibrosis used to be like, which is that patients come in, they're short of breath, they may have chest pain, they look sick, their saturation is very low, and so people are afraid to exercise them. But done right, the same exercises that help people with COPD and pulmonary fibrosis are the same exercises that will help people with heart disease and pulmonary hypertension and heart failure. All right, couple of questions, other questions. Now, this is another question that I hear over and over and over again. So people say, I don't understand this. Why am I short of breath if my oxygen is 95%? Okay, good question. And if you think about what I spoke about before when I was talking about obstructive and restrictive diseases, okay, what we were talking about was the mechanics of lung function, and in other words, the mechanics of moving air in and out. Okay, when we talk about oxygen saturation, what we're talking about is chemistry, biochemistry, and biophysiology of how your body uses oxygen. So the good news is, if you're short of breath but your oxygen is still 95%, by all means that's a lot better than being very short of breath and having an oxygen that's 85%. Okay, what it means is that there's other factors besides your body's ability to use oxygen that are making you more short of breath, and it could be mechanics. So if you have an obstructive disease, it means that you're having difficulty blowing the air out. If you have a restrictive disease, you have difficulty bringing the air in, okay? It could be your conditioning. So if you're used to walking, you know, if you just retired and, you know, according to your job that you did last year, you had to walk up 20 flights of subway stairs a week, and now you're not doing those 20 flights anymore, guess what? Your legs got weaker, your muscles got weaker, they don't use oxygen as well, you're more short of breath, okay? Or if, you know, a lot of times patients come to me, they say, I don't understand this, 3 months ago I wasn't short of breath, now I'm short of breath. I say, what's changed? They say, nothing. Oh yeah, I gained 30 pounds. Okay, so now let's talk about weight. So the mechanics of breathing again, if you put 30 pounds around the stomach, okay, one of the things that happens when that diaphragm contracts downwards and the lung inflates, okay, is that the rib cage elevates and expands. So if now all of a sudden you've got 20 pounds on each side of your ribs pulling down, that's that much more work that your diaphragm has to do. Okay, it's like you have a pack mule and you've just overloaded him with weight that he's got to carry, okay? And now again, let's go back to that thing that I talked about before, which is that now you're more short of breath. You have to work harder to move that air in and out, and the harder you work to move that air in and out, the more airway narrowing you get, the more trapping you get, and the even harder you have to work. And it's this cycle and cycle and cycle. And now anxiety kicks in, and now my adrenaline's pumping, and I'm breathing harder, faster, and it feels like my heart is beating out of my chest, right? And you see that every single thing that I have been talking about from the first minute to now is all connected, okay? So I'm floating like a butterfly, stinging like a bee to weave this tapestry for you so that you understand that nothing happens independently, okay? And the more of these tools that you get, and the more of these tools you can use, and the more that you see how these things relate to each other, the greater control you have over your own breathing and over your own health, okay? That is my goal. So here's a question from Dale. How long can you go without oxygen before it affects your organs? If you mean without oxygen completely, okay, that means like a respiratory arrest or a cardiac arrest, meaning you stop breathing or your heart starts pumping 6 minutes before you start to see organ damage, okay? If you mean, you know, I walked to the bathroom and I didn't wear my oxygen, and so when I came back, my oxygen saturation was, you know, was in the 80s, then, you know, that is not going to start killing organs for you, okay? But the thing is, a lot of times people think, well, you know, they say, well, I did desaturate, however, I came back up very quickly. But it's really important to understand you don't want to be desaturating, okay? Because when you desaturate, it really increases the workload on the heart and the other systems of your body, okay? And the problem with that is that if you are somebody who may have heart disease or coronary ischemia or arrhythmia, all these things will increase the likelihood that those things will occur and potentially increase your chances of having a heart attack or a myocardial infarction. So you do not want to let your oxygen go down and fiddle around with that, you know, on a regular basis. Here's a question. When I'm driving in my car and I lean back on the seat, it seems that the pressure on the spine causes numbness in my chest and face. Could this be COPD related? And my answer is no, okay? What it is probably more likely related to, okay, because all of the muscles, all these muscles that we talked about, these all come, so the muscles of the face get their nerves from the cervical vertebrae, okay, which is the vertebrae of the neck. These muscles in your chest will get, you know, some innervation from the neck, but mostly from the thoracic spine, okay, and those nerves. So when you're leaning back, in all likelihood, what's happening is you're probably causing a little bit of a disc compression, and that disc compression, okay, is probably pressing on the nerve root that innervates the face and the chest, and what else did you say? And the chest and the face. So, you know, what I would suggest in a situation like that is have an evaluation, maybe have either an X-ray or an MRI of your neck to see is there anything going on, something like a spinal stenosis or a bulging disc or a ruptured disc, and all those things can be treated in some way, or can, you know, whether it's through physical therapy or something else, but it's worth looking into if it's something that happens on a regular basis. Okay, other questions, and this is another question, then I'm going to go to all the questions that are being asked online right now. Why is it that when I walk on the treadmill I could walk for 30 minutes and then I go outside and I have to stop after 15 steps, okay? Again, this is in the exercise videos, okay, so watch it, but I'm going to explain it very simply. Couple of things. There's many reasons for this, but in a nutshell, the main ones are this. When you're holding on to the treadmill, number one, you're more stable, okay? So you're holding on, you're more stable. You're taking the weight of your body, and instead of dividing it amongst two limbs, you're now dividing it, if not equally, you're still dividing it amongst 4 limbs, spreading out the load. Okay, that's one thing. The other thing is that the treadmill is helping to bring your feet back. So there's going to be naturally a greater resistance when you walk outside or even when you walk inside as compared to when you're walking on the treadmill. So when you're walking on a flat surface outside, that is the equivalent of walking on a 2% incline when you're walking on the treadmill. Okay? So that's something to keep in mind. But from a respiratory perspective, okay, the muscles of my chest, back, shoulders, when my arms are free, I'm calling this freedom of my arms open chain activity. And when my arms are in an open chain, the muscles of the chest, back, and shoulders and arms do things like this. Okay? So they raise my arms, they lower my arms, they bring them out, they bring them in. When I'm holding on to the treadmill, or leaning on a table, or leaning on a walker, or leaning on my shopping cart when I go to the supermarket, this is called closed chain activity, because look what's happening here. My arms are fixed, okay? And when you are in a closed chain with the upper extremity, all of the muscles of the chest, the back, the shoulders, okay, work in their reverse action to help elevate the rib cage and assist with breathing, okay? So my suggestion to people very often is they say, I can only walk a half block. I hand them a 3-wheel walker and I take them out for a 5-block walk, okay? So if you really can't walk around, I know a lot of people say, I don't want to use a rolling walker, but guess what? If it means you can all of a sudden start walking again, put your vanity aside and at least use it long enough to help you start building back some of the conditioning that may ultimately allow you to walk more without the rolling walker. Okay, I hope that answers that question. All right, let us go to some of these questions online. So, here's a question. I was diagnosed in 2012 with IPF, which is interstitial pulmonary fibrosis. Years ago, I was told that I had COPD. Can you have both? I know that COPD is constricted, but what you mean is obstructive, and IPF is restrictive. So, unfortunately, okay, you would think that, you know, if you work Saturday, that would exclude you from working Sunday, but unfortunately, when it comes to obstructive disease and restrictive disease, having one, unfortunately, does not preclude you from having another, okay? And what that means, if you think about it, you can have both an obstructive component to your disease and you can have a restrictive component as well, meaning that you have trouble with both phases of inspiration and expiration. And if you think about it, interstitial pulmonary fibrosis or idiopathic pulmonary fibrosis, we don't know what the cause is, right? So if you were going to get, you may or may not have gotten idiopathic pulmonary fibrosis anyway, and then add to that a 2-pack per day smoking habit, or, you know, working in a factory or so on and so forth. And so the short answer and the unfortunate answer is that yes, you can have COPD and pulmonary fibrosis, doubling the challenge for you, okay? But that doesn't mean quit. It means that you have to work even harder and be even more aware of the lifestyle changes that are going to help you maintain your lung function and also hopefully improve your lung function. Next question. Have you seen one lung affected more than the other? And the answer is yes. There are some people who one lung is much worse than the other. And, you know, there are many, many different reasons for that. I don't know all of them, but that's not something that can be determined from a pulmonary function test. That's going to require either a CAT scan or a more complex test. Okay, after being on oxygen for 2 liters for many years and coming off, will there be a side effect? How long will it take for the body to operate on less than 100%? Diagnosis is pulmonary fibrosis. So if I'm understanding the question, I think I understand the question. After being on 2 liters for 2 years, what will happen when I come off? So let me talk about a couple of things. Oxygen is given and prescribed on a supply and demand basis. So in other words, if you're chilly, put on a sweater. If it gets warmer in the room and you're getting warm, take the sweater off. And this is all going to be based upon your pulse oximetry. You do not become addicted to oxygen, okay? So a lot of people feel like, I don't want to start this because I don't want to become addicted to it. You do not become addicted to oxygen, okay? So there shouldn't be any type of withdrawal or anything like that. If you have improved to the point that your body now utilizes oxygen efficiently enough to maintain saturations in the 90s, then you should feel perfectly fine. All right, next question, can sinusitis mucus drain into the lungs? The answer is yes. So anything, you know, all this stuff is kind of connected. So the way that the respiratory system works in the sinus system, so you have all these sinuses here, right? They drain into the nose or the throat. And so you have your nasopharynx, air enters the body through either the nose or the mouth. It goes back. If it comes in through the mouth, it goes to the oropharynx. If it comes in through the nose, it goes to the nasopharynx. They meet in the back and they go to the pharynx. Most of the time, this mucus is just swallowed, okay? But it is possible that this stuff can drip down into your lungs. So first of all, for anyone who's got any bad sinus mucus, I would always recommend some type of saline rinse. And what's the best way to clean out the lungs? Okay, you know, deep breathing exercises, use of the positive expiratory pressure devices like the Acapella, the lung flute, the Quake, the Aerobica, and we do have a webinar called How to Keep Your Lungs Clear and Free of Infection. So check that out. It's a good question. Next question. Every so often I get a nosebleed from blowing my nose. Could too much oxygen cause this? And the answer is, it is possible because oxygen is very drying, okay? So if you think about it, when somebody cleans a floor in a commercial building, what do? They blow air on it to dry it, okay? Same principle. So what can you do about this? Number one, make sure that you're not dehydrated on a systemic level, meaning that you're drinking plenty of fluids, okay? Make sure that the oxygen that you're getting, that you have an actual bubbler in it, so there's an actual cup that can be attached to most oxygen systems so that your oxygen is coming through the water, and it gets a little bit of humidification there. It's not going to be the total, you know, it's not going to totally undo the oxygen, especially if you're on high concentrations or high liter flows. And then the other thing is to make sure that the ambient air around you is humid. So if you know that you live in an apartment where the heat is very, very dry, then by all means put, you know, some pans of water on those heaters so that the air is being replenished with, you know, and increasing the moisture or the humidity of the air. But in my opinion, one of the biggest factors in that is really making sure that you're very well hydrated, because if you're dehydrated, it's going to dry out all of your systems. How can one strengthen the diaphragm? The best way to strengthen the diaphragm is vigorous aerobic exercise, okay? Diaphragmatic breathing, all these little breathing techniques that people do, okay? I'm going to say something that might make people mad. I'm sorry, those things are not going to make you significantly less short of breath during activity. The best way to improve the strength of your diaphragm, the strength of all your respiratory muscles, the strength of your heart, to improve your lung function, to make you less short of breath, is vigorous aerobic exercise, okay? It's not going to happen by sitting in the chair, breathing in through your nose, out through your mouth. Now you have to do these breathing exercises so that you can learn them, so that you can learn to incorporate them into the vigorous exercise. But it's that vigorous exercise that's going to make the change, not those breathing exercises. The breathing exercises are the gasoline that allows the car to drive, okay? All right, next question. Breathing is like work for me. Its effect, is that short of breath? Yes, that is short of breath. I don't know that I understand the question. My breath is not short. Okay, that answers your question. Okay, can massage of the accessory muscles help in a management program? Absolutely, and shout out to my person right there. I recognize you, and I know that you're into massage and healing arts. Absolutely, massage can help, okay? How does massage help? Think about it. How many of your neck hurt? How many of your shoulders hurt? How many of your chest muscles get tight? Why is that? Because you are using accessory muscles of your neck, of your chest, of your shoulders, of your back to breathe. Those guys aren't supposed to be breathing, okay? Those guys are supposed to be supporting. They're the accessory muscles while the diaphragm does their work, okay? So if the diaphragm is not working properly, okay, then those muscles have to work harder, harder, harder. And those muscles get super tight, And when those muscles get tight, guess what? You get pain, you get spasm, and you have to work even harder. So massage will help to bring blood flow to that area that doesn't get the blood flow because the muscles are in spasm. Massage will help to lengthen those muscles. Massage will help to eliminate the waste products that are in those muscles. Massage is awesome. Just do it. Okay, next question. In ILD restrictive disease, we have confusion as well. For example, we have the type of PF called NSIP, so non-specific interstitial pneumonia that has an NSIP pattern of lung tissue damage, but NSIP pattern is not unique. Oh yeah. With IPF, in addition to known cause, you must have UIP, which is usual interstitial pneumonia or pneumonitis pattern of lung. Okay, I am with you, Barbara, okay? This is such a complex topic. It's even more complex than obstructive lung disease, okay? Last month, we had a super genius of interstitial lung disease, Dr. Robert Kaner, on the show. And let me tell you, I went to school that night and I learned so much, and it really came clear to me for the first time, the clearest it's ever been of my career, how to classify these things. This webinar is going to be up this week, okay? I expect it to be up by the weekend, okay? So watch it again. We're also going to be summarizing and putting the key posts and the key points from it on it. But believe me, interstitial lung disease, it is a super confusing topic even for clinicians. And you know, that's why it's so hard to treat and often misdiagnosed. But the webinar was awesome, and I'm not talking about myself, but we had Dr. Robert Kaner and Bill Vick, who's a patient with IPF, and they really cleared up a lot of things there. And so I encourage you to watch that again. Next question, what are the causes and characteristics of asthma that make it different? I think we talked about some of that. It's what exercise can I do to improve my breathing with asthma? Again, same thing. Learn the breathing exercises, start out slow, start increasing the intensity, but it's going to be, over time, progressively increasing vigorous aerobic exercise. Okay, are inhaled steroids effective in restrictive lung disease? They are not often used in restrictive lung disease, but again, everything is going to be done based on what your doctor says is right for you. If you have multiple lung conditions, for example, I have COPD, bronchiectasis, asthma, alpha-1, acid reflux, is there any hope for lung function to get better? And one other question is that, will there be a day where I feel like I can go all day without stopping and no shortness of breath? Why will there be some days where I feel wonderful, like I can go all day, and other days where I feel really bad? Again, breathing is multifactorial, so it could be related to weather. It could be related to what you ate. You mentioned that you have acid reflux. So if you had, you know, a half a pizza pie, and now your stomach is churning out acid, and that acid is spilling over into your airways, and now your airways are trying to protect you by constricting, that's going to make you more short of breath. But that's a complex topic, and we're running short on time. Is there an inhaled version of prednisone for treatment? And the answer is yes, and it's the inhaled corticosteroids, of which there are many. Most patients today are having combination drugs like Advair or Dulera or Symbicort. Does too much oxygen cause nosebleeds? I think we talked about that. No sympathy. Those that play with sharks are either crazy or out of their minds. I take that personally, but I don't want your sympathy. It's okay. Question, some people are being prescribed morphine for anxiety and sometimes for cough, but isn't morphine a central nervous system depressant? So the answer is yes, morphine is a narcotic. It is a central nervous system depressant. So it can make breathing a little bit more difficult. But if anxiety is the main factor that is making it hard for you to breathe, or one of the main factors, or I'm just sitting here and I'm working myself up, then maybe the morphine might be enough to, you know, to take the edge off it. All right, so I realize I'm rushing now. I'm gonna tell you this. I'm gonna do 10 more minutes. And then I'm going to do another webinar next week where I'm going to cut any questions. I'm going to get to any questions that I didn't hit tonight. There's a lot of questions here, and they're all good questions, so I'm happy to see this. Next question. I am a respiratory therapist at a small hospital In Eastern Canada, we have a small pulmonary rehab program, but the wait list is very long. I always discuss the importance of exercise with my patients, but worry about a patient pushing themselves too hard initially and ending up in the emergency room. Do you have any recommendations or guidelines for people with chronic lung disease who want to start increasing their exercise tolerance? I realize it's patient specific, but what's a good starting point? Brilliant question, okay, often overlooked. The key is the initial examination and the initial exercise test, okay? But everything that we do here at the Pulmonary Center is fully monitored. So with our patients, everybody is on an EKG the whole time that they exercise. We're checking blood pressure in 5-minute increments. We're checking oxygen in 5-minute increments. But in a situation like this, I don't know how much monitoring you do or you don't have, but I would say without the EKG, there's only so much that I can do, okay? That's my main tool. But what I would use that's very effective is the RPE scale and the dyspnea scale. If you think about the RPE scale, which is the Borg scale, okay, which is rating of perceived exertion, in general, the overwhelming majority of the workout should be either fairly light, somewhat hard, or hard. So we're talking about 11 to 15, right? So if it's very light, then the workout is too light. Okay, that's like my porridge is too cold. If it's very hard, then my porridge is too hot. So we want our exercise program to be just right. And in general, if you teach the patients the correlation between their heart rate and their blood pressure and their oxygen saturation and where they are, I don't say to people, is it very, very light? Is it very light? Is it fairly light? No, I only use 3 things because it should either be fairly light, somewhat hard, or hard. If it's anywhere below that, the workout's too easy. If it's anywhere above that, the workout's too hard. But you know, that's a complex question, and this is for the person whose initials are CH. Feel free to contact me, and this is a discussion that I can help you with and that we should talk about, because there are probably some things I could teach you that will make your program significantly better with not that much difference in the amount of effort that you have to put out. All right, wow, so much adrenaline, what a cycle, sounds familiar. Okay, now you know how I feel. I can see the need for a frequently asked questions section on your website with reference, and I thank you, Barbara, for starting to write those questions for me. I agree with you 100%, but I have a book coming out very soon, and that will answer your FAQs. All right, why is it you know what, I have to stop here because there's about 20 more questions, and they're all good questions, and I don't want to rush through these questions and do them a disservice because they really are important. And you know what, you can learn just as much from the Q&A session as you can from my main lecture. Okay, so I'm gonna stop here. You have my word, I will reconvene with you next Wednesday night, okay? And I'm gonna try to do a Q&A, if not every other week, if not every week, at least every other week, because I see there's plenty of questions, and I'm back from vacation, I'm refreshed, I'm full of energy. As you can see, I'm full of hot air also, but I'm ready if you're ready. So let's reconvene here in 1 week, and I'll hit the rest of these questions. And if there's other questions that you may have, feel free to email me, noah@pulmonarywellness.com. All this information is in previous webinars. Go to college with us. www.pulmonarywellness.com. Thank you to the American Lung Association. Thank you to my online Facebook groups. If you want, subscribe to our YouTube channel. It's under Pulmonary Wellness. And have a great evening. I hope you found this helpful and beneficial. And to those that say I'm either crazy or out of my mind because I swim with sharks, I am not. I'm out of my mind for other reasons. Have a good night, everybody. Thank you for joining us.